Welcome, everyone. Good. Excellent. Hi. I'm actually so unbelievably properly happy. I had a speech and everything, and I wrote it all down, and it was all going to be really nice and kind of put together. And I'm just sat here going, there's so many of you. And it's just so lovely because it means the absolute world that we've got you all here and we've got people watching. And it's just so amazing to have everybody back in one space again. And I think it's just, yeah, it's brilliant. To be able, it's the first time that we've done this, to have this many of you here is absolutely fantastic. So welcome. Thank you for joining us. So obviously we're at Harlow Study Centre. We've got a load of people that are also online as well. I don't know how many we've got at the moment. 75. Fabulous. So welcome to those online as well. It's brilliant. So obviously we're going to be here tonight, hopefully finishing off maybe about 8:30, 8:45. We've got some lovely speakers that are going to be here. A little bit of housekeeping to start with. So for those of you that haven't been here before, if we go towards the back and turn right, that's where our toilets are. So they're just on the right-hand side. With regards to fire alarms and so forth, if there is a fire alarm, I don't plan on there being one. I was joking with the guys over there earlier. There's definitely not going to be a fire, okay? Stand down, it's all good. If there is a fire alarm, out of our fire exit, so we've obviously got one straight out to our side, or we could go out the back if we needed to, and the muster point is out the front at the white building. Okay, so we're just going to make ourselves out there. If you haven't signed in, if you could, that would be great, just so that we've got a register of who's here, just so we can keep an eye on that. We'll take a break. So hopefully we're going to take a break at about 7:30, dependent upon our other speakers, and then go from there. With regards to the guys that are joining us online, if for whatever reason anything happens with your live stream, drop out, restart your laptop, turn it off, turn it on again, and join back in on the same link. So hopefully they'll be able to come back and join us again. So why are we here? We're here because ultimately this is something from the CFR training team we kind of want to give back to you guys. Okay, so I've got myself that's going to kind of effectively stand to one side in a minute, and welcome to the guys that are going to come and join us. We've got Vicky Darby, who obviously looks after our training team. So she kind of looks after the whole of the training side of things, from commercial as well as CFR training. We've got the lovely Silka, Professor Silk Walter, and we've got Rianne. I said it right. Okay, Rianne, who have come from the mobile stroke unit. So again, joined us from quite a distance, and they're going to come do a really lovely bit about the clinical side of things. And I've kind of had a bit of a look at their slides, and it's full of awesome stuff. And then we're joined nicely by Naresh as well, who's come from the Stroke Association, who's going to do a bit of a talk about the community side of things, so what they do when those people are going back out into the community. And also we're going to be joined by Alex Murphy, probably later on when she joins us, to just kind of do a bit of a talk about her stroke survivor side of things and give us her personal story, which I think would be really, really nice for us to be able to get that side of things as well. So hopefully it'll be a lovely evening for you all. If you've got questions, but you don't feel like you kind of want to put your hand up, catch us, write it down if you don't want to kind of speak out to us at the end, and we'll make sure that we ask them to Silka or to Vicky or Naresh when they're here. But please, yeah, feel free to ask those questions. Any questions to begin with? Everybody happy? Everyone got a drink? Yeah? Brilliant. Definitely wasn't beer I was drinking, Ron, okay? It wasn't beer, all right? So let me introduce you first of all to Vicky, and she's going to kind of talk a bit about the CFR side of things for a little bit, and then we'll move on to our next speaker. So please welcome Vicky Darby. We'll go straight into your next slide. Thank you.
Hi, good evening, everybody. It's wonderful to see so many of you here tonight and meet you face to face after such a long time. And I hope that you're here and enjoy the evening that Liz has put together for you. So this is your CPD day. Liz has chosen stroke awareness after you all put it out to vote, and that's what you wanted to see. And she's worked really hard to kind of do that and get you here today. So one of the main things I wanted to say, pretty much just straight off the bat, was a massive thank you to Liz for doing this, and for you guys as well, because without you, we wouldn't be able to be doing this CPD evening. We wouldn't be able to do anything, give our patient care. So that's absolutely amazing. Also, I'd like to thank Silka and Rianne as well for being here. Alex, when she comes, and Naresh as well, absolutely, for being here and to be able to make this evening fantastic. So we hope you enjoy it very much. Now, Liz has given me the rather grounding job of talking about scope of practice, because you're going to hear some wonderful things tonight, but we need to make sure that we work within our volunteer scope of practice. So thank you. Yes. And just as a kind reminder as well, you can find your scope of practice on the Trust intranet as well. Now, when I sent this slide set through to Liz, she kindly said to me, "You've got something on your slide, just one word, there's nothing else." And I was like, well, what on earth am I going to say in a group full of experts? So it's not my place to talk about this. But what I wanted to remind us all just very quickly is the signs and symptoms that we will look for as volunteers, because there are loads of signs and symptoms that the stroke team will go into. But it was just as a kind reminder, the things that we will commonly see in the volunteer realm would be, it'd be usually sudden, sometimes with a headache, quite often with paralysis. So what are you guys going to perform if you notice that? Oh, look at you go. Okay, fantastic. Difficulty in speaking, maybe some facial palsy as well, and maybe decreasing levels of consciousness. They may have flushed skin, a slow bounding pulse when you take your observations, and sometimes a noisy breathing, especially if their airways become occluded. And they may have, when you do your sample history, they may well have pre-existing blood pressure problems or cardiac problems as well. And for us, our treatment is simple, but quick and effective. So it's always making sure that you're safe, always making sure that patient can respond, making sure that there's no catastrophic bleeding, making sure that airway is open and clear, and then, if necessary, as you rightly said, performing that fast test and making sure you get your hot one back up and it's being directed to the right resource, which would be you in this instance, and doing your fast test. Doing what you do best, which is giving our patients reassurance whilst they're waiting for that ambulance, and making sure you're recording those baseline observations so that you can hand over to your clinician when they get there. To use oxygen therapy if it's indicated, and you've got the tools for that. And as I look around the room, I can't even imagine how many years I would count up of experience that must be here. So it is just as a reminder, as I say, of our scope of practice, to take an event history and especially noting that time of onset so we can be as quickly as possible with this patient, and to finally document all your findings and give your handover to the crew using ATMIST. But I'm sure you've perfected your own technique as well over the years. And so finally, just a massive thank you to you all for being here tonight. And thank you to our guest speakers as well. And again, a massive thank you to Liz and her husband, Phil, actually, who's sitting there quietly for putting this on. So thank you very much. Thank you.
So we're now going to hear from Silke and from Rianne, so going back to just what Vicky said, it's great. We're going to be given so much information, and it's just remembering we kind of just need to ground ourselves a little bit, possibly. But it's amazing. So I met Silke, oh crikey, a few months ago, wasn't it, when we were in Martlesham. And when I met Silke, it was the biggest advocate, wasn't it? You kind of said you've met some CFRs and out when you were working, come and join me, and you can kind of. So I think
Hello, good evening.
Welcome, Silke.
Hello.
But yeah, you'd met a couple of CFRs, hadn't you?
Yeah, it was just brilliant. I really admire what you're doing. It's just absolutely fantastic. And it's a really great pleasure. Thank you for inviting us today.
It's really lovely. So yeah, I'll hand you over to Silke. We've got your slides, so either feel free to click through here or you've got that. And we'll go from there.
Lovely, thank you.
It's all yours.
So hello, my name is Silke Walter. I'm a neurologist. I've got a funny accent. This is caused by my German background, unfortunately. And these are not my slides.
Yeah, no, keep going. You're good.
All right.
Keep going.
I keep going. And then here we are. So the topic of today is stroke. You know about that? And what I would like to do is I would like to give you an introduction. What is a stroke? What do we have to consider? Why do we have to run? Why is it important to be very, very fast with our treatment? It's quite important to know why. We can feed that back to our patients. We can actually feed that back, and you know very well about that, to anyone. It's very important that we emphasize this if we speak to every member of the public. And in addition, I would like to introduce our hybrid mobile stroke unit ambulance, which is a very, very special ambulance, which we have in Martysham, and Rhiannon and I work together on this ambulance, together with some other colleagues. It's the only mobile stroke unit ambulance in the UK at the moment. There aren't any others. There are centres who are preparing to get one started, but this is the only one, and it has been the only one since, I just met one, who is this gentleman who I just met, who was with us in here, there he is, in Southend already, when we started trialing this ambulance in 2018, that was. All right, so just some background information. And I always find that quite important, because we all know we have to run when there is a heart attack. We all know there are very many serious medical conditions, but stroke is a very, very common thing. And it can happen to all of us. It can happen anytime. There is one stroke every 5 minutes. That's really a very high number. We've got many stroke deaths, which is also a horrible drama. And I emphasize that because there are excellent treatments. I will come to that a bit later. So we can do something against stroke. It's the 4th leading cause of death and the leading cause of disability. And we have to keep in mind, being disabled not only affects the patient, that's horrible for the patient, but also the whole family. This whole life is affected. Very many people are involved in that. We've got very many stroke survivors, but the problem is the number of stroke will rise. We will have many more patients over the next couple of years and decades. And this is why it's really important to look into what we can do to make treatment better and to improve treatment access. That's probably the trickiest part we have to manage at the moment. And when you look to got a pointer to the right-hand side of this picture, please, quite impressive is, we all know that our brain is full of nerve cells, but we lose 2 million nerve cells per minute untreated stroke. And you know how quick a minute goes. Per minute, 2 million are gone. And next minute, another 2 million are gone. And this is why we really, really have to run. Running is a tiny bit compromised, or is made a bit more difficult by the fact that actually stroke is not just the same thing for every patient. There are different types of stroke. And you might have seen some of these words already in some of the letters you find with our patients. So we've got brain infarcts, and the medical word for brain infarcts, which is sometimes written on these discharge letters, is ischemic stroke. On the other hand, we've got brain bleeds, and they are called hemorrhagic strokes. And what I've put underneath is, these are brain images, different types of brain images for both types of stroke. And you can see here, I'm not sure whether, can you see that this is a bit darker? Is that visible until, oh, wonderful, perfect. Sometimes it's difficult in the projection, but this is darker. This is dead brain tissue. And this is a brain infarct. That's actually a CT scan, a CAT scan. This is an MRI working with magnetic field. This looks a bit different, but here it's the whitish area, which is the stroke. This picture shows you, and this is something I will address later on again, that shows us the arteries in a patient's brain. And normally, there should be an artery going from here, from this big one, that's the neck artery, going to here. And this is blocked. And in a brain bleed, we see in the CT scan this whitish area here, the white bit here, white here, white here. This is blood. On a CT scan, blood looks white. So we've got 2 different types of stroke. And the really difficult situation is we don't know without having an image. Symptoms are the same. We can't differentiate that. What causes a stroke? We've got this brain infarct or ischemic stroke. And in such a situation, we've got a blood clot traveling into the brain arteries, and it can just travel as far as it can go, depending on its size. And then the arteries get tinier and tinier, and depending on the size of the clot, it gets stuck. And behind this area then, we do not have any blood flow, which means no oxygen can reach these nerve cells, and what happens? They die. This is a brain infarct. A brain bleed, a hemorrhagic stroke, is more or less not the opposite, but in this situation, very, very often caused by high blood pressure. Very, very often, these patients with a brain bleed have a very, very high blood pressure. You might pick that up when you take observations. What happens is we've got areas which are tiny bit susceptible in our arteries, tiny bit susceptible to high blood pressure, and they can rupture these arteries. And then we've got a brain bleed. It bleeds out of this artery. And what happens in this situation? There is still blood, there's still oxygen, but there's a huge pressure because there is no space for this additional blood, which flows into the brain. And this affects our nerve cells. And again, our nerve cells die. And what we see as stroke symptoms this is exactly caused by dead nerve cells. So nerve cells who are, for example, responsible for movement of the right arm. If the stroke happens there, we can't move our right arm anymore. As said, it's quite tricky because we can't see it from outside which type of stroke it is. But why do we have to know that? Because treatment is so utterly different. You can't treat a patient with a brain bleed in the way you treat a patient with a brain infarct. You would actually kill this patient. So this is why it's absolutely most important to identify the type of stroke. And we need a brain image for this. The quickest way or the easiest image, which usually exists in every hospital, is a CT scan. And this is just a picture of a CT scanner in a hospital. Patients need to get taken to this CT scanner, and then we know what it is. Brain bleeds, on the left-hand side, they are the minority. They are roughly 15% of our stroke patients have a brain bleed, while the brain infarcts, they are 85%. And I've mentioned just 2 slides ago that these brain arteries, they are important to know because they are very different, a very important and severe type of stroke, which is this one here. We call it large vessel occlusion stroke, and it actually is what it says. It's a brain infarct caused by a very large blood clot, and what happens is one of the very large brain arteries gets occluded, and of course, easy to imagine, this causes very, very severe symptoms. I'm sure you've all seen these patients with very severe, dense paralysis, very severe stroke symptoms. They usually have a large artery occlusion, or if not an ischemic stroke, a brain infarct, they've got a large bleed. Again, this is important because their treatment is different. Luckily, we can treat strokes, and this is an information we also have to give to our patients. So it's not all lost, it's not all horrible. We can treat strokes, there are causal therapies, and they are excellent. For brain infarcts, we've got, and this was approved in 2000, actually in Europe, in America that was a bit earlier, we've got a clot buster infusion we can administer, which dissolves the blood clot. Then blood can go through again through this artery, and the nerve cells can get oxygen and all their nutritions. Unfortunately, and this is what I mentioned, what I meant with treatment access, only 11% in our country get treated. So numbers could be much higher, but we can't reach the patient. Patients who have a large artery occlusion, very, very large blood clot, they need an additional treatment. They also need, if possible, this clot buster infusion, but they need a treatment which is very comparable to what we do with patients who have an MI. They have to go to the cath lab, and nowadays, these blood clots, these large blood clots, get pulled out with a catheter. So, like an MI treatment, catheter treatment also for the brain. And we have known that this is needed for these patients since 2015, so quite a while. So it's very clear that patients with brain infarct need these treatments. However, treatment access is difficult. Why? Because it's all about time. 2 million nerve cells per minute untreated stroke, which means the earlier we treat, the better it is. This slide might look a bit different, but I will take you through. The only thing it shall explain is the faster we treat, the better it is. Unfortunately, in medicine, not every treatment can heal every patient. Or actually, there is no treatment which can heal every patient. That's the better way to say that. We always treat and know that some patients will not benefit. And there are hundreds of reasons for that, multiple. In stroke, one of the main reasons is time. So patients with a brain infarct who do not get their clotbuster infusion very, very, very early, they have a lower probability to benefit from this treatment. And this is exactly shown here. So patients who get their treatment within the first 90 minutes, and this is not after emergency call, this is after symptom onset, we treat, and this is the green mannequin there, we treat 4 patients and 1 will benefit without any disability. The others might improve, but they will keep some symptoms. 1 will have no disability, and this is exactly what we want. And we know already, and these data come from results from the mobile stroke unit ambulances. If we treated every patient within 30 to 40 minutes, we actually 60 to 70% would survive without any disability. Unfortunately, it's really tricky to treat patients that early. This is why we've just heard that once you identify stroke symptoms, feed that back. It's so very important that we speed up this pathway. And you see easily on this slide, the longer it takes to get treated, the lower is the probability that a patient stays without any disability. And that's very sad. Very important is, and this is now actually addressing you all, or actually everyone, every clinician at scene who comes and sees a patient, and this patient might have a stroke. First important point is identify this patient. And I've now changed it a bit from fast to be fast, because I thought, why not actually find what you're doing each and every time we meet a first responder? This is such high quality. I thought, okay, we do be fast. So I hope that's all right. So fast, you've already heard. It's face, arm, speech, and then time. Be fast is an additional 2 more symptoms, because what we know is fast symptoms, we have some certain types of stroke which are not picked up by fast. The B in be fast means balance. And some patients with stroke in their coordination center, they can't walk upright anymore. They are very wobbly. Some patients can't sit anymore because they just fall. And this is a clear sign of a stroke. It can be many other things, as can be speech problems, but it can be a sign of a stroke. And this is the B in be fast. The E, which then comes, is eyesight. A sign of a stroke can be that a patient can't see anything anymore. Sometimes this is only half of the visual field, half of the vision. Sometimes one eye is black. Very important. Document these symptoms, feed that back to the next crew that takes over. And then, of course, face, arm, and I would like to address speech again. Very often, we get handover from, and this is not only community first responders, can be anyone more or less, saying, oh, well, speech was fine, it was just slurred. Slurred speech is not normal. Slurred speech can be a sign of a stroke. So document that and register that in your mind as, oh, that's not all right. It might be all right for this patient, but at this time of the assessment, we don't know. So we have to keep that in mind. And then, of course, it has to be very, very quick. While you are there with the patient. Of course, you have to reassure the patient that everything hopefully will be all right and more help is on the way. Relatives the same. There's quite a lot of work, but if there is time, it would be absolutely fantastic if you could start collecting information. We already have that. When did it start? And we see that every time we are out with the MSU, and each and every time we are the first ones to arrive, you ask, when did it start? And they say, I don't know. All right, just roughly. Well, maybe yesterday. All right. Or maybe this morning. So it's very difficult because patients are stressed, relatives are stressed. It's really difficult. And sometimes they probably have to think about it. Try to pinpoint down as much as possible. Pinpoint it to the start of a single symptom. Dizziness, for example, is very difficult to pick up a time of onset. Usually they can't answer that. But if you find an additional symptom, try to ask, but the speech problem, when did that start? Or this arm weakness. If they can't say the overall start of these symptoms, try to go through every single symptom to get a time of onset. This is incredibly important for us. And Rianne can probably add the story of the first MSU patient she had. We thrombolized.
Come on up. Yeah. Come on up, lovely. This is exactly a story which explains how difficult it is and how important it is to really cut it down.
Hello, everybody. I'm Rianne, paramedic, so I work with Silke on the mobile stroke unit. Not at the moment, I'm pregnant, but yeah, usually. So our patient, it's one of the very, very first ones that I attended with Silke, and we arrived on scene and the crew had said that the patient had got slurred speech, is that right? Yeah, and the onset was
day before.
Yeah. And had been accompanied by a headache. So immediately you sort of think, okay, all right, we'll go with that. And yeah, that's probably going to dictate the course of their treatment from that point onwards. But this is where it's so important to really dig into the history of each symptom. So we asked, okay, so when did the headache start? Yeah, that was definitely yesterday. Okay, that's good. Right, okay. And the speech, and then I think just little by little, it became apparent that the speech problem was today. And actually it was 3 hours, 4 hours,
exactly,
something like that. So within the stroke treatment window, which is 4.5 hours for thrombolysis. So at that moment, the stroke symptom, which is the speech problem, was within treatment time, and we were able to then treat that patient, and it had a really positive impact on that patient's disability. I don't know if you know about the mobile stroke unit, but it carries a CT scanner, so we were able to scan him there and then, see that it wasn't a bleed, and administer the clot busting drug, which was such a positive outcome for him. So the key message there is we could have definitely overlooked that by thinking, okay, so his headache started yesterday, and that would have been the end of it. But by really questioning symptom by symptom, we found out that the stroke symptom, which is the slurred speech, was today, within treatment time. So yeah, it was a really positive outcome. So it's just a reminder to
really dig deep.
Yeah, and get each symptom by symptom.
Thank you. Okay. So that would be absolutely important and would help a lot. Then, of course, previous history. What other diseases are there with the patient he suffers from, or she? Medication. Medication is always important. Some medications cause some certain symptoms and also then lead to another treatment later on. And I've now put also potential contraindications for clotbuster treatment. And they are actually quite easy. Clotbuster treatment is an infusion which makes your blood really thin because we want to dissolve that clot. So contraindications, situations in which we cannot administer this drug, they are just situations in which we are very worried that we cause a bleed somewhere else in the body. Can be the brain, can be anywhere. And this is why recent surgeries or previous large bleeds anywhere, they make us think, is it more beneficial than it can cause harm? So these are situations we would be very grateful to get as quickly as possible this information. Of course, allergies are important. Some people are allergic to some certain drugs. And then always, sometimes you arrive at hospital and you think, oh, I still need to know this information, and some patients can't answer anymore. Then it's very important to have someone to phone and to know who to phone to get some further information. So that's the information also we collect as first thing. These are our first steps. And I know that very many of you do that. And I've just heard that obviously this is part of your training. We always are incredibly grateful for getting kind of a written report, because sometimes it's very stressful. Patients can deteriorate. They can be very, very poorly. You get a handover, but then it's an emergency situation. We're all very focused, but sometimes you think, okay, how was this? I just now forgot that. And we are already on the way to hospital. And then you're very grateful to have a sheet in your hand, and you can say, all right, okay, everything is written down here. Wonderful, perfect, sorted. This is incredibly helpful. We would, for a perfect handover, it's always very nice to first hear the actual emergency situation. What has happened? Why have they called? Then clinical findings, your assessment, and you do that absolutely brilliantly. Each and every time we've met first responders, that was just brilliant. Then previous history, then additional information. Just that easy. And then the next crew, whoever comes, has to take over. And this is, I think, the most beneficial and the quickest. We know from studies that the better this handover is structured, the quicker the next step in the treatment and management cascade is. The overall problem with stroke is that, and unfortunately, this still is the case, patients come too late. And this is why treatment numbers are still so low. I mentioned only 11% in the UK get clotbuster treatment of patients with brain infarcts. This is because somehow we don't get them. And Rian mentioned that the treatment window is 4.5 hours. I haven't mentioned that before, but that's absolutely correct. From symptom onset to the latest time point we can infuse this medication is 4.5 hours. There are special situations, but they need very special assessment then. We can't do that everywhere. It's 4.5 hours. Why is that? Because after 4.5 hours, the risk of causing a bleed by this very strong blood thinner increases. And this just the balance between making it better and causing harm. And at the moment, this is 4.5 hours. Well, patients don't arrive early enough. We can't get them. And very often, unfortunately, I must add that now, this is why, because I always hope that people spread the word. We meet patients and they say, well, I haven't called earlier. It started 3 hours ago. And I thought maybe it goes away. The problem with stroke, I always find, is it's not painful. For a heart attack, they would call immediately because it's so painful. Stroke is not painful. They don't want to bother anyone. They don't call. But it's so sad because they just reduce their chance to improve. And they make it really hard for us to treat them. In 2003, and you can see now a photo of Klaus Fassbender, who is the inventor of the mobile stroke unit concept. And this is what I would like to introduce now because we love this project. And there are many of these mobile stroke units now worldwide. In 2003, just after we had the clotbuster treatment, the problem was that we also, in those days, we didn't get any patient to hospital in time for treatment. And the idea was, all right, if they don't come to hospital, why don't we go to the patient and take everything we need to diagnose them and start treatment at the emergency site? Well, that's not that easy because you need a CT scanner. You need an image of the brain to know what has happened. The design of a mobile stroke unit is that a CT scanner is on board of an ambulance together with blood machines, with machines which can test the patient's blood, and with telemedicine connection to hospital to transfer images, but also to get feedback from hospital specialists if needed. And there are different implementations of mobile stroke in different areas of the world, and sometimes they are all staffed in different ways. So sometimes there's more feedback and sometimes less feedback is needed. The first mobile stroke unit, and it looks very different. Some of you might have seen the current mobile stroke unit, which I have on another slide. That was the very first mobile stroke unit, the first we had on the worldwide first one. And it started in 2008. That was in the southwest of Germany. It was quite a large lorry, you can see here. It had a CT scanner with a control room that was all lead shielded in those days. That's not necessary nowadays anymore because scanners have changed. They are much smaller. There's no radiation coming out of them. But even with this quite big ambulance, with this very special equipment inside, it was possible to differentiate between brain infarct and brain bleed. And this is what we need. We need to know what's going on, and then we can start treatment. What was very clear from the very first moment on was that, and when you see the MSU bar up there compared to the control is just standard care, treatment with an ambulance then to hospital, and hospital analyzes what has happened in the patient's brain and starts treatment. You can see many more patients could be treated within the first 60 minutes after symptom onset. And when you remember this picture with the little mannequins, the earlier the better. When we can treat them in the very first 60 minutes, that's just brilliant. So many patients stay without any disability. And this is what we want. Unfortunately, with traveling to hospital, then in-hospital pathways, this all sums up and takes longer. Well, 2003 was the first publication about a mobile stroke unit concept. We are in 2023 now, so it's quite a while ago. And we have in the meantime, we've had many studies confirming how much better it is for patients. And what this slide shows is results coming from all studies put into one pot. And then they analyzed what is the outcome for the patient. They wanted to know, and this is called excellent outcome here, whether it's beneficial for patients staying without any disability. You can't notice anything at all anymore. Good outcome means patients have some symptoms left, but they manage without any support at home. And any better outcome means that patients improve but keep symptoms. And you can see this is a very special way of presenting these results. They are the scientific results coming from all these studies. And each and every time you can see these bars here on that side of the graph, it favors mobile stroke unit treatment. And you can see they are here and here, which means patients in a mobile stroke unit, and they are only the treated patients compared to patients treated in hospital, they are doing much, much better. And this only comes because we are much faster. All these results together, they were put together by the European Stroke Organization, and they have now recommended mobile stroke unit treatment for the pre-hospital care of acute stroke patients. And there are many centers worldwide which use mobile stroke units, and there are more every several months. There are some more. So it's just, this is the last figure we prepared is from 2018. There are very many more now. Australia, they have now started changing their stroke management on the whole continent. So they get MSUs in every area. They actually have started, and they have have progressed quite a lot in the last months. They will get an MSU in an airplane to reach their remote areas because it's so beneficial for the patients. And to give you an idea of how these ambulances look like, they are just some examples here. And you see the first thing one sees on this slide is they all look different. When you see an ECG, they look very similar, but here they all look very different, and this is how it has to be. And this is, they must be different, they must be implemented into the local system, which means every health system is a bit different, every area is a bit different. It might be hilly in some areas, there might be narrow roads in another area, it might be like the American ones, they are this one here, they've got wide and big roads, they can have really big ambulances. So this is very, very important. There are very many different small little tiny changes coming with every of these ambulances, but the overall concept is to diagnose a stroke patient at the emergency site and to start treatment. And I always like speaking about that's Thailand down here. They've got 8 ambulances now. And they've got an interesting concept. They actually have, I mean, this shows you how important it is to integrate it into the local system. They've got kind of an app and patients can subscribe to that. I don't know whether that is that comes with a certain kind of fee, but if the patients then think they've got a stroke, they can press a button on this app. Then they get connected to a person in the control room dedicated to stroke care. And this person then listens to all these symptoms. And if this person thinks that this patient might have a stroke, they dispatch this ambulance. This is how they do it. There is an ambulance in Argentina. They've got the CT scanner integrated into their ambulance, not fixed. They can actually move it in and out, and sometimes they use it in the operating theater, and sometimes they use it as mobile stroke unit, just as they need it. So every area has it adjusted to how it would be best for them to operate such an ambulance. And the one here, this is the one you might have seen on East Suffolk roads already. This is the ambulance we use. And because we operate in East Suffolk, we have extended the project slightly. And this is now the next slide. We are operating a so-called hybrid mobile stroke unit, which means we know that stroke is an emergency. Very clearly, we all agree on that. So are accidents. So are heart attacks. But also other medical conditions are very, very urgent and need an immediate treatment, like patients with severe infection, like patients with seizures. The risk of patients with seizures is they can go into a continuous seizure, which is called status epilepticus. And unfortunately, to make it more difficult for us, very often we can't see that from outside. Very often patients, especially patients with previous brain disease, previous brain damage, they just lie still. They don't do anything anymore. We can't see any jerking. They just lie still and they've got a status in their brain, so a continuous epileptic seizure. Of course, epileptic seizures, as do stroke, they kill nerve cells. So we want to stop that as quickly as possible. And what we have done is we have upgraded our equipment. So instead of only carrying a CT scanner, we now carry on the imaging side a mobile X-ray as well to do chest X-rays. We carry an ultrasound machine to do ultrasound of certain organs depending on where symptoms are. We've got a huge laboratory unit. We can measure full blood count, infection parameters. We can measure blood salts, electrolytes, kidney parameters, cardiac parameters as well. We are connected to hospital and radiologists report the images back immediately. And we have in the electrophysiology side, you might know this machine, which is the ECG. Oh, sorry, it's on that side. The ECG, which is very familiar to you, but we also have this machine, which is measuring the electric activity of a patient's brain. That's an EEG. And with this EEG, we can see whether a patient has a seizure, whether that seizure is still ongoing, or whether it has stopped. And you can see on the other hand, on the other side of the slide, you can see that's the inside of the ambulance. It just looks like a normal ambulance, except from that there's a CT scanner at the back. Otherwise, same size, no difference. What is the aim? the aim of this project is to treat faster, and not only stroke patients, but also patients with sepsis, also patients with seizures. Why have we included these patients? Because East Suffolk is quite a rural area, and very, very often it takes us 40 minutes to travel to the patient. And if that patient then had an infection, severe infection, it would be a shame to not start a treatment. But also, what we do is we want to direct the patients to the necessary level of care, which means that is a case we had actually many months ago, it's quite a while ago now, a patient, and I'm not sure whether any one of you is from Suffolk, north of Sexmundham, very, very severe headache. We went to there, patient had collapsed in the shower. There was a first crew from Sexmundham, they were the first at scene, and they then reported back to us that this patient complained about this very severe headache and presented with a really, really slow heartbeat. Because we were a bit further away, we then met on this quite lovely meadow. Sorry, it's always the wrong side I'm turning to. On this meadow, and then we scanned the patient. And what you can see on the CT scan, it might be a tiny bit tricky. It's a bit whitish here, just a touch. This is a very, very special type of brain bleed. Comes from an aneurysm which had ruptured. It's called an SAH bleed, subarachnoid hemorrhage bleed. Very special type of bleed. This patient had already affected the lower areas of the brain, causing the really slow heart rate. And what happened then was, because the patient was so severely affected, and because we knew what had happened, we could call HEMS. HEMS came. Patient was transferred from the meadow in that situation, because we all met there, directly to Addenbrooke's, was in the operating theatre for surgery 2.5 hours after we arrived and started the diagnostic workup of the patient. And this was just a very, very brilliant result, and the patient survived without any disability. So by knowing what the underlying reason for these symptoms is, you can direct the patient. And this does help not only the patient, actually the overall system. What we can do is, or what the aim is, we go to the emergency site and we decide, can we manage that here? Do we need help coming from the GP? Very often, with the results we gain, we can speak to the GP and suggest some treatment, which then can be done by the GP. And they are very grateful for getting all these results. Some patients have to go to hospital, and then the question is, which hospital? Can it be Ipswich? Can it be the next district hospital? Or would the patient be better off to go to a larger centre like Addenbrooke's? That would be our tertiary care centre. And this is what we are doing with this ambulance. We are seeing patients with headache. They can have a brain bleed. We've just heard about that. That can be a sign of a stroke caused by a bleed. Patients with suspected stroke, suspected by the dispatch centre, but also patients with seizures, patients who are unconscious. Very often, and they are actually quite nice cases, we go and see patients who had a fall on their head. For example, they are in a nursing home, are regular fallers, had a fall on their head, are on blood thinners. They all have to go to A&E, get a CT scan to see whether they've got a brain bleed after this fall. We go see them, we scan their brain. If they don't have a bleed, they can actually stay at home, which is really nice for them. We do see patients who are sick, that's a general code, because they can have an infection, as can have patients with breathing problems. And this ambulance is staffed with a paramedic and a neurologist, funnily. Neurologist because the brain, we've got very many brain patients, brain diseases. This is the leading disease group we treat, and this is why we've got a neurologist on board. And we are connected to hospital, which means we've got remote support if we need that. And does it do anything good? We think so, and these are the first results. They were actually published 3 years ago already. This was from the South End phase. When we compare to standard care, which means ambulance and then hospital treatment, and these results are for stroke patients, we have a pre-hospital phase of 65 minutes, and then in hospital it took 75 minutes to get the patient treated. And with the mobile stroke unit from emergency call to treatment, that was just 42 minutes. So it's much, much quicker. However, you can see that still the time from symptom onset to treatment is quite long. Patients must call us earlier. And you know very well how difficult it is to raise public awareness that it's really, really important. First symptom call. Don't wait. It might go away, but you don't know. If it doesn't go away, that's really bad luck. And that reduces every chance of recovery. From the Suffolk mobile stroke unit work, we have quite an interesting, and I mentioned that we can decide what level of care the patient needs. We have interesting results, and that was especially during the pandemic. That was very interesting because with this management, with all the equipment we've got on board, and that was analysis of 250 cases, 86% of these patients did not have to go to A&E. This is good can be good for the patient and also reduces pressure on A&Es. How did that happen? 46% of the patients were managed by either staying at home with support of their GPs, of additional care, and 40% of the patients went to the target ward directly, meaning that with a stroke patient, you wouldn't go to A&E anymore because that patient is diagnosed, treatment has been started, so you can go to the stroke unit directly. And then these patients get an earlier stroke unit care, which again improves their outcome. That makes it better. We know that stroke unit treatment makes it much, much better for stroke patients. They have less disability. So that's this triage advantage. And I hope there are very many questions, and I thank you for your attention. Yes, please.
So you say we've got one.
Yeah.
Thailand have got 8.
Yeah. Yeah.
Just clarifying that.
Well, it's always a funding problem. So this is quite a funny project. So this project is funded by that's a collaboration between my actually German home university, the East of England Ambulance Service, and Ipswich Hospital. It's not super cheap to put a CT scanner on board of an ambulance, to train staff and to operate this ambulance. But, and I say but, because of course we've got such a lot of data now that this has been analyzed as well. And what we know is that the more patients this ambulance treats per year, the more cost efficient it will be. It depends on how much a society wants to pay as threshold to have one patient without disability. And this is a very country-specific threshold. There are different thresholds in the UK. This threshold is at around about £30,000 per case. And while, for example, in Australia, they are very rich in Australia, I find, they actually can go up to $50,000. So that is very different. To answer your question, it's always a question of funding. There will be more mobile stroke units coming in the UK. So I assume the next one will be Nottingham. They are very quick with setting one up. And then the question will be, who pays for that? Because at the moment, they are all operated as a research project with special research funding. But we are now leaving this stage of actual research because we know it's better. It's proven, it's clear. And this is why in many countries now it is the health system, whatever that is, that's again different from country to country, the health system starts taking over and funding these treatments. Because actually, a CT scanner is 400,000. That's the extra bit. That's the main bit. An ambulance is an ambulance. That's not more expensive here. The ambulance is exactly the same. Just the CT scanner needs to be there. And then there are different possibilities to staff such an ambulance. We staff it with paramedics, a senior and advanced trained paramedic, and a doctor. That doesn't have to be like that. This is only because we operate in a rural area, and what we test at the same time is whether we've got telemedicine connection. In Cleveland, in America, before they started, they actually put up very many masts to get better mobile connection. So they never had any doctor on board, which makes it more cheaper. So these are always all questions which need to be answered before it can be implemented in a way that it can be available anywhere. Yeah. At the moment, we think that one unit can operate or can serve 1 million inhabitants. That's just the rough number. Yeah. Yes.
I'm really sorry, this is a silly question.
No, I'm sure that it's not. There can't be any silly question.
Are there ever stroke patients that don't have symptoms like drooping around or blurred speech or not being able to use their arms?
Yeah, very many.
Because you were talking about the symptoms, which sort of slightly bothered me. So the onset of stroke symptoms.
Yeah.
So you're saying not necessarily to go from headache, but other symptoms like stroke.
Yeah. So very many patients do not have the classical symptoms. And unfortunately, very often this is in women. I'm not sure whether you've heard that patients with a heart attack, that symptoms can differ between men and women. Same for stroke. This is not well known. It's not well investigated. Sometimes you can be only confused. Sometimes you can only have a headache. It's a devil which can hide a stroke. But the classical symptoms are face, arm, speech, sometimes only one of these. Vision is very common, blurred vision, but there can be other symptoms as well. And both these symptoms are then confusion, dizziness, lightheadedness. Yeah, these are the main symptoms, and headache we mentioned.
Which could be like anything.
That makes it so difficult. That makes it really tricky. And this is why sometimes I can understand that people don't dare to call, because in probably 80% of these cases, this is not a stroke. But still, it's not right. It's much better to call, and then we are quite happy to say, luckily, it's not a stroke. That's much better than having someone who had a stroke and then it's too late for treatment or patient stays with disability. Yeah, it can hide, really, a stroke. There are many other symptoms. It always depends on the brain region where it sits. Yeah.
We've got a few questions online, if
Yeah,
that's okay.
yeah.
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 Do you want to go to Ron first?
So it's where are your radiologists placed? Are they mainly in call centres or places like that?
Yeah, they can be anywhere because we are connected via telemedicine. So they work for Ipswich Hospital, but they work for this project for Ipswich Hospital, but they also have other day jobs. So actually, we still have a colleague coming from Southend. But when they work for the mobile stroke unit, they work for their Ipswich Hospital, on their Ipswich Hospital contract. Because I don't know actually how you can imagine that it's just connected via mobile data, which means they could be anywhere, but of course they are here in the UK.
It's far bigger now than it ever was.
Yeah, very true.
Yeah. Doing lots and lots of work.
Yeah, that is true. They're all in the UK. They all work for Ipswich Hospital when they work for this project, but they are physically not always in Ipswich. Yeah.
Anyone else? Yeah, go for it.
Sorry if you've already said this.
Maybe.
What's the course of treatment for someone who's had a hemorrhagic style stroke?
Yeah.
Because you wouldn't want to give them clotbusting drugs, but
Yeah, that's a good question. I have not addressed that. Very true. You've picked that up. It's difficult. So the question was, just to repeat that, and it's an excellent question. Thank you for that. What do we do when we've got a patient with a brain bleed? What's the treatment? It is the current treatment we've got is to the stroke unit as quickly as possible, adjust the blood pressure. They all of them present with high blood pressure. That's an automatic regulation of the body of the brain to work against this increased pressure which we receive by having more blood in the brain. There's an artery which ruptured, blood flows out of this artery into the brain, there is more pressure, there is more volume. Our bone is quite hard, so when we normally have a bruise on our leg, it can expand to the outside. But this can't happen in the brain, it's just too hard, it doesn't work. So blood pressure adjustment, we have to lower this blood pressure, otherwise it will not stop bleeding. If this patient is on blood thinners, we have to stop them from working. There are antidotes, not for all of them, but for many of them. In very special situations, these patients need a brain surgery. And in addition, they are also quite active. There's quite active research going on, investigating special drugs which stop the bleed immediately. What we've learned already, likely these drugs they work, but they must be administered very, very, very early. And likely in hospital it's too late because these studies were negative. They now try to administer them earlier. We know these drugs from when someone has a large accident with a major bleed, we administer them. But for the brain, it's still not proven that they work, likely because they were too late. So there are multiple things coming together. And it is not as easy as saying, well, this is what we do for hemorrhagic stroke. Unfortunately, it's very individual. Some have to go to surgery, some don't. Some need a very special blood pressure treatment, some don't. It's just quite tricky. So we probably need another 10 to 15 years to make that better. It's not ideal.
Just going to jump in really quickly and answer a couple of ones online, if that's okay, guys, because we've got loads of questions coming in. Bear with us. We've got one from Adam, which says, whose decision is it to deploy the MSU? Does it have to be requested by CAL?
No, this is just the emergency call comes in. We get, sorry, I have to look into the camera. We get dispatched directly through the dispatch center, or we can receive crew requests. So if another crew is at scene, if you are at scene actually somewhere, probably not in Essex, but in East Suffolk, and think, all right, these are clear stroke symptoms, then we can get requested. And if we are free, if we don't have another patient on board, we are very happy to come and see that patient and help.
So would that be done through
control? Always through just normal control room. Yeah. But not, yeah.
Thank you. Which one have we got? Daniel, so is the MSU available 24/7 or is it only available during certain hours?
Yeah, it's only available during certain hours, and this is just purely because we don't have enough staff, not enough funding to staff it 24/7. And why did we limit it to 9 to 5? It is Monday to Friday, because 9 to 5 during daytime is because to treat a stroke, we need to know the rough onset. And patients who wake up with their symptoms, they usually can't give us an exact time of onset. You can treat these patients still, but you need very special assessment. And as this is only the start of these ambulances in the UK, we've limited it to one team, and we just do our 9 to 5 hours.
Fabulous. We'll go back to the room.
Yes.
If you give blood thinners,
Yeah.
obviously they've taken that medication within the blood, also for a lot of reasons. How often does that affect the other? Why they have to take it? Do you
All right.
prepare to treat that
Yeah,
blood?
no,
If they have blood thinners?
Yeah. So the question, if I understand that correctly, is if we have a patient who is on blood thinners and we add more blood thinners, is that correct?
No, if you have to reverse the blood.
All right, okay. So for patients with, for example, a brain bleed, and we have to reverse the blood thinners, that's a good question. So for example, to give a practical example, a patient who has a deep venous thrombosis and needs blood thinners to not develop another clot in the leg. Then this patient has a brain bleed, and we have to stop the medication from thinning the blood. Very excellent question. We have to take the risk. We have to just monitor. We have to take the risk. There's no other possibility. Yeah. Very, very good point.
So
But
knowing why they take
Yeah.
it is very important. for us
Exactly.
to know
Yeah.
as well.
Exactly. But I mean, deep venous thrombosis is one example, but there are more severe or more difficult situations. For example, patients with a new heart valve, which is, there are some metal valves. They really need blood thinning. Otherwise, it's really, really dangerous. It's a very tricky situation. So it's important to know why they take that. And then we have to do this really difficult balance.
Thank you. Anyone else? No, fabulous. Got a quick question which has come in from somebody on Facebook. Has asked if a hypo patient was to fail the fast test and may not be obvious they are diabetic, how can the CFR tell the difference?
Not possible.
No.
Not possible. Just not possible. Yeah. Very many situations you can't, without additional assessment, you cannot diagnose it.
Yes.
Unfortunately, not possible. No one could.
Yeah.
So, yeah.
And the other question that I've had that's come in is how often are you used during your
All day long.
All day.
All day long. We start our shift and very often we come back very late. So we just, if we get a call 1 to 5, then we just out. Yeah. All day long.
You don't stop.
No, we don't stop. We eat on the go. Yeah.
We are.
All right. Oh, yes. All right.
Lots of stuff online.
All right.
I was going to say
Okay.
we've probably got quite a substantial amount from potentially other areas that are online. So I know there's quite a few in Suffolk and Norfolk, CAMS area.
The patient has to be a patient of Ipswich Hospital to be eligible.
Right.
So for your CFRs that are in Suffolk, just so they know that.
Okay.
If the hospital that they're going to go to would be Ipswich, then we will absolutely come and see them if we're on.
Brilliant. Would you mind? I'm not sure if voice was picked up. Would you mind just repeating that, just in case?
Oh, right. Yeah. Sorry. So that was just
so that they
one
can hear.
comment. Patients we see, because this is a collaboration between Ipswich Hospital, East of England Ambulance Service, and Saarland University, which this means that patients we see, they have to go to Ipswich Hospital. This is a governance reason. So that is just what Brian mentioned. We can see anyone, but patients then have to agree to go to Ipswich Hospital.
Any more questions?
I have one.
Okay.
Sorry.
Sorry, just actually it's the two. So the clot, is that caused mainly by like AF?
All right, now I answer that. Yeah, okay. Shall I answer that first? Or okay, so good question. So what is the reason for a blood clot? AF is very correct, is the most common reason, but there are other reasons, which are, this would then be a so-called cardioembolic stroke. Blood clot comes out of the heart, of the cardio is the medical term for heart. Then it travels to as far as it can go, depending on its size. It's a tiny one, it can go very deep into the arteries and then it gets stuck. It's a big one, it gets stuck earlier. There are other types of, or other reasons for stroke, which is atherosclerosis, is the medical term, which is hardening in the large neck arteries. And there are risk factors for this hardening, which is smoking, a lot of alcohol, high blood pressure, high blood cholesterol, diabetes. These are the main risk factors. There are others, but these are the main risk factors. And then we all would develop hardening in our arteries, in the large arteries and in the small arteries. And as soon as this process has started, clots can form there. Or a tiny bit of this hardening can actually travel into the brain and block an artery. So there are different types of blood clots. Yeah.
And then the other one, the other type. So you said that you might have, you've got somebody with really high blood pressure.
Yeah.
You've got maybe areas of those blood vessels that become susceptible.
To a rupture, yeah.
And is it because of the high blood pressure that's constantly made that more susceptible, or are we all potentially susceptible? And then if you have high blood pressure, it can make that worse.
No, it's they get more susceptible. The longer you've got high blood pressure, the more fragile your arteries are, because what happens is when you've got decades of high blood pressure, high pressure going into kind of a tube which is elastic. What does happen with high blood pressure? Normally it would expand this tube, but the body knows it shouldn't. So it gets stiffer and stiffer and stiffer, and it builds up this hardening. And as soon as it does that, it's not flexible anymore. And if then there is a very high pressure for a certain amount of time, it can rupture because it's not elastic anymore. So this is caused by this high blood pressure. Unfortunately, to make it a bit more difficult, this also comes a bit with age. So the older we get, the less elastic our arteries are, the less flexible they are. Yeah.
And I think there was a question from the back as well.
Yeah, statistics, I was just going on first. 1.3 million people live with a stroke event. And you've got predicted to increase by 32% by 2035.
How?
There's a bit more stuff on that.
Yeah. So this is just, there are for every country, there is research going on to estimate, and this comes by, we are all getting older, and this is all goes into this calculation. We're all getting older. The older we get, the longer we will live with risk factors, lifestyle changes. So we very often, and I also do that, so it's not, we come home, sit in front of the television because we are tired. We don't move a lot anymore. This is a risk factor, which I haven't mentioned right now. It's a huge risk factor. Diet changes. We know our diets have changed dramatically, and this is just not healthy. Risk factors increase. To put it together, all this leads to that. People get older. The older we get, the longer we live with risk factors, the higher is our risk of getting a stroke. And this increases the number of stroke victims overall. This is how they calculate that. But that's, of course, different from country to country. There are countries in which there are very many obese people. They have a much, much higher number. Yes.
We do aortic scanning.
Yeah.
To see if people are building into the artery and is the aorta. What about carotid scanning? Because if you look at some of the CT scans that I've seen, you actually do see the narrowing developing and sometimes branches being very nearly occluded quite often. But they're not offensively scanned, they're only scanned on admission.
Yeah, that is very true. I would be absolutely happy to have to scan not with CT scan though. Exactly, ultrasound. Ultrasound is not doing any harm to anyone. Scanning everyone regularly would be brilliant. I actually just think it's a bit too expensive for a society. That's the problem. On the other hand, as far as I'm aware, it's not done in any country, regular scanning. People can request it on a private basis, but I'm not aware of any country in which regular carotid artery scanning is done. But that would be brilliant. I completely agree.
£140 if you want it done, so I'll try.
On the other hand, what I have to mention is, once we see, and this is what we always have to keep in mind, once we see hardening at the aorta, it's just one artery, and we are one body. We belong to, it's not isolated, the aorta. Once we see it, somewhere in the body, it's everywhere. Hardening in one artery means there are more arteries with hardening. It can't only be one. It's impossible. It's just all too connected. We are one body. Yeah. So if someone has a heart attack caused by an artery occlusion, this patient also has hardening in the brain, 100%. It does not come alone, which then brings us back. Each and every time we've got that very strict management of risk factors, no smoking, no alcohol, healthy diet. Healthy diet is Mediterranean diet, interestingly, is healthy, which means vegetable, fish, as little as possible meat. Some nuts per day are healthy. Olive oil instead of other oils or fats, and going out for walks. So when you go out for a walk every day, walk as fast as possible, a minimum of 30 minutes per day. It reduces the stroke risk dramatically, because the body wants to, or does everything it can to make it better, which means the more you walk, the more you do physical exercises, the more new arteries get built, which then helps you or helps your body to perfuse, to send blood into the different organs. Yeah. Yes.
So you showed a slide about the drug, the big
Yeah.
drug, and obviously extent of removing the
Yeah.
clots. With really low figures that actually receive that treatment.
Yeah, that's true.
Is that because we don't get to them quick enough, or they don't throw it in quick enough, or is this another cost implication?
No, that's not unfortunate. No, unfortunately, it's half-half. Patients don't call early enough. This is certainly a very, very huge factor. Yeah, this is why. Yeah, there are some countries, and they have started doing stroke awareness campaigns in schools because this is a problem in every country. They've started doing stroke awareness campaigns in schools with the aim to already teach children, pupils, what stroke is and what the immediate action must be, call an ambulance. Then the next problem is that, of course, I've mentioned that sometimes we travel, it takes us 40 minutes to reach a patient on blue lights. If that patient calls, let's say 4 hours after symptom onset, we with the ambulance manage to treat that patient because we are quick enough. Or probably by, 4 hours, then still not, because it would take us 40 minutes. So we would be after 4.5 hours. And then traveling time back to hospital for normal ambulances also adds to that. So if both comes together, traveling times to the patient, then in hospital, they need some time to do the image and to analyze them. That all takes time. If this comes together with a late call, that's the problem. So we have to work on both ends, more or less. People have to call earlier and have to call each and every time they've got a symptom. They don't know whether it's a stroke or not. And also we do all the assessment because we don't know by just looking at them. And then also the management must be optimized. But I mean, there are very many campaigns and very many efforts to work on that. Yeah.
When is the project scheduled to end, and then what will happen to this ambulance and its equipment when that does end?
Yeah, well, it will end likely. It's always in a research project works in a way that you have to give a research plan before you start it, and then you need a certain number of participants, and once you've reached this certain number, you pull out the data and analyze what you've got, and then you see whether it's beneficial or not. Likely it's very beneficial because we know that already from many other centers, but we have to prove that because the special situation here is we've got more equipment and we operate in a rural area, quite rural. Even though we are parked at Martlesham, that's where we are based, we operate in the very rural area of Suffolk. What happens to this ambulance once this project ends? I actually don't know. This depends on, what the stakeholders decide how things shall go on then. So, unfortunately, I don't know.
How long? Much longer?
Sorry, 2 years. 2 years. Sorry. Yeah, that's something I can answer. What happens next? Then I don't know.
Anyone else? Fabulous. Thank you. Thank you very much.
Well, thank you very much. Thank you also for the questions.
I think, are you planning on staying around for a little bit? You're going to stay with us for a while? Or do you need to shoot off?
You stay a bit.
Stay a little bit? So what we'll do, I think, is everyone's happy, is we'll take a short break, 20 minutes or so, grab a tea or coffee, have a chat, catch Silk if you need to, or Rianne, or Vicky or myself or anyone else, and the rest is obviously here as well. And we'll come back to you shortly.
Just say exactly what time.
So for the guys online, if we come back at 20 to 8, so 7:40 to come back, and we'll be ready to go again. All right, thank you very much.
Thank you.
Thank you. everybody back online and everyone's back in the room. Fabulous. So I'd like to welcome our next speaker, which is Alex. And Alex has kindly come along to talk about her personal story. Now, I did just speak to Alex and Hannah, who's her boss.
Yeah, she's my manager.
Definitely, definitely at the back. I stalked Alex quite dramatically, to be fair, and I did have to apologise on the phone when I spoke to you. I don't know if any of you recognise Alex. Alex was on Dancing on Ice, and it was very, very kind of prudent to bring Alex along tonight, and I'm so grateful for her being here because Alex had a stroke, as she's going to talk about, and I think it's really important that we kind of link the clinical side of it. We've spoken about our scope of practice, so to have Alex come and share her story is brilliant. So I will hand you over to Alex. Thank you very much.
Thank you. Hi, everybody. I'm like, hello. So for those of you who don't know me, my name is Alex Murphy. I am a professional figure skater, and I recently won ITV's Dancing on Ice. Great crowd already. I love it. You probably figured out quite quickly from my unfortunate accent that I am an American. And maybe you gathered now knowing that I was on Dancing on Ice that I am an athlete. But what I bet you'd never assume about me is that I had a stroke. I'm a very proud stroke survivor, and I'm here to tell my story to you all today. I've been an ice skater for as long as I can remember. The minute I learned to walk, my mother had me running around the house in diapers and ice skates. Skating has been and always will be part of my identity. When I reached the age of 17, I was such an adult, of course, that I decided that college wasn't the path that I was about to take. So I packed my suitcase and I began what has been and still is an incredible professional ice skating career. When I was 24 years old, I chose to work on board cruise ships on the Navigator of the Seas in their ice show. November 6th, 2012 was the day my entire life changed. I now look back at this day as my stroke anniversary. I remember it very vividly. I had just taken my final bow and I skated off the ice towards the backstage as I had done hundreds of times before. But this time was going to be very different. As I was walking, I started to feel pins and needles in my right foot. Nothing too concerning. Maybe I had had my skates on for too long. Maybe the rink was a few degrees colder that night. And as I started to untie my skates, I had a sudden realization that I had lost feeling in my right hand. I couldn't untie my skate. I tried to lift my arms, and my right arm lay there limp by my side. I went into the bathroom and I stared at myself in the mirror, and I had no idea who I was. I was staring there blankly, face drooping, right side fully numb. I couldn't move. I couldn't shout out for help. I couldn't cry. It felt like I was trapped inside my own body. I knew that the world was moving all around me, but yet I was completely still, locked inside my body, frightened and scared and unable to tell anyone. When I regained full consciousness, I woke in the ship's hospital bed, unable to talk or move my right side. I couldn't read, I couldn't write, and I had zero forms of communication with anyone. All I could do was cry. It still felt like I was trapped, unable to tell anyone what was going on, yet able to see and understand everything that was around me. The worst part about my stroke is that I still remember the looks on everyone's faces. I remembered how shocked they were and how they had no clue what was happening or what they could do to help me. The doctors even drug tested me as they weren't sure what was going on. How could a healthy athlete at 24 years old be showing symptoms of a stroke? It didn't seem possible even to trained medics. I stayed in the ship's hospital ward overnight as we cruised towards the Canary Islands, and in the morning I was taken to the hospital for an MRI. For 9 days, I was sentenced to stay in Tenerife in the neurological ward where not even one person was under the age of 68. It was the worst 9 days of my life. They rigorously tested me for anything and everything. I hardly moved, had no contact with the outside world, and I was under bed rest until they could find out what was wrong. A day ago, I was a 24-year-old professional ice skater traveling the world. Now I was bedridden and had no idea if I'd ever be able to move or speak again. In broken English, I could understand the word stroke, but I still had no idea what it really meant. And at 24 years old, I had no idea what a stroke was, what the symptoms were, or how it could have happened to someone like me. As my speech slowly improved, the Spanish doctors okayed me to fly to Miami for more tests with US doctors, where they finally confirmed that yes, it was a stroke. I had kept things very quiet about what had happened, and ironically, on that very morning, I received a call that I was going to be on the Dutch version of Dancing on Ice. Doctors did the final test, and they found that I had had a hole in my heart. A few days later, with that confirming the cause of the stroke, I had emergency heart surgery to put a device in my heart to close that hole. Less than 3 weeks post-op, I went off to compete in the Dutch Dancing on Ice. My partner was a 6'4" Dutch reality TV star, and lo and behold, it was almost exactly 3 months to the day of my stroke that we won the entire competition. Now, I know that I'm one of the lucky ones. I know that I am the luckiest girl in the world, and I know that this happy ending is likely not the case for millions of other survivors. But for me, I was still trapped inside my own head, and I was completely embarrassed, and I didn't want to talk to anyone about it. Between undergoing heart surgery and then winning a TV show, my life had completely flipped upside down. I looked fine, but on the inside, I wasn't. I had constant brain fog, and I was always tired. My skating wasn't what it had been pre-stroke. My reading and my writing abilities weren't what they used to be. My hands and feet were always numb. I couldn't concentrate, and I was horrified to sleep alone. I would wake up crying in the middle of the night and have to ask my friends to come sleep in the same bed as me. Months before, I was this independent, confident, 24-year-old girl that knew everything, and now I just wanted my mom. I tried to completely ignore the fact that I had just had a traumatic brain injury, but it wasn't working. I was highly emotional, and my moods were all over the place. I was in complete denial of what had happened to me, and I was almost angry with myself and everyone else that was around me. I should have been on cloud 9, having just survived a stroke and now won a TV show, but here I was, miserable and completely uncomfortable in my own skin. I hated the way that people looked at me when they found out. I hated the pity that they had for me because I was so young. I hated the way stroke made everybody cringe. And I hated the way that my smile was now ever so slightly crooked. At that time, I didn't realize how lucky I was, and I am still today. And at 24, wrapping my head around the idea that I could have died, well, all it did was give me anxiety and fear that it was going to happen again, despite doctors telling me that they thought I was going to be fine. I was angry, and I didn't understand why it had to happen to me. So I pretended like it didn't happen. As years passed, I referred to it as the time that I got sick, or when I got sick. I was so afraid of not being normal. Part of it was quite practical. My job was in jeopardy anytime management asked for my medical history to perform. It still kind of is to this day. When people ask for it, I still get anxious as I know what their first question will be. I'm otherwise healthy now, but stroke survivor is still a badge that I have to wear. The more jobs I apply for, the more people I meet, the more questions I have to answer. You can imagine how awkward it is dropping the stroke bomb on a first date. It took 10 years to finally wear this badge as a badge of honor and to realize how important sharing this story is, but not just for me. My stroke was the best and worst thing that ever happened to me. When I was diagnosed with my holy heart, my mom and dad were tested as well. My mother was found to have the hole and my father didn't. A year and a half after my stroke, we found out my dad had been misdiagnosed and he suffered a stroke as well. Because of my trauma, my mom knew all the symptoms of a stroke and she in turn saved my dad's life. I thank God it happened to me first. I thank God my mom knew the warning signs, and I thank God my dad is fine today because of her, because she acted so quickly. Dad and I are now part of the special stroke club that nobody knows the password to unless you've lived through it like us. And a few years ago, I was approached by a company called Different Strokes, a charity organization here in the UK during my first season of the UK Dancing on Ice. They asked me to share my story. At first, I was so reluctant to speak to them. It had been 5 years. This was behind me now. I had moved on to a completely different life. I needed to put it all behind me and to pretend like it didn't happen. I was so wrong. The minute I started speaking to this organization, it was like a weight had been lifted. 5 years later, and those memories were coming back as if it had just happened yesterday. Wanting to help other survivors has selfishly become my own rehab. By giving back, I get so much more than they will ever know. Every single stroke is different. Every single survivor has a different story. The more stories that I hear, the more I realize how important it is to share my own to create awareness for these young survivors that can't share theirs. And what you guys are doing here today, volunteering all of your time and your energy to help save people like me, you're doing your part to prevent stories like mine. And I hope you know that we're so grateful. Everything in life happens for a reason. You're meant to be exactly where you are at this moment. You're meant to be sitting in these chairs right now, listening to some random American tell you a story about cruise ships and ice skates and sparkles and strokes. I was meant to have my stroke, if only to inadvertently save my dad's life. Spreading awareness, spreading positivity, spreading knowledge, that's why we're here. My stroke could have completely ruined my life, but I know I'm so lucky. If I hadn't had my stroke while I was on the ice, I would never have been around a medical team that was there firsthand to help me. If my stroke hadn't happened at that exact time with those first responders around to take care of me, I wouldn't be alive now. Life is extremely serendipitous. The way I look at life now, these rose-colored glasses that I wear, the happy feeling that I have 99% of the time for just being alive, there's not a day that I don't feel constant gratitude to the people around me that helped save my life. I'm thankful every day that I have my stroke, but my stroke does not define me. It was my wake-up call to remind me to always choose happiness. It was an experience that inadvertently helped me save someone else. It's the reason why I'm a Bostonian girl living in London, talking to you all lovely CFRs today, and for that, I'm so grateful. Thank you so much to every single one of you for everything you do, and thank you so much for taking the time to hear from survivors like me. You truly don't even know the appreciation we all have for the people like you who save lives every day. I feel so lucky to get to speak to you all on behalf of those that can't, and we're forever eternally grateful to you all for everything that you do.
Thank you, guys. Has anyone got any questions for Alex before she goes? Anybody? No? We're all good. Okay.
Said a lot. I said a lot.
Thank
you guys for having me. I really
Thank you
appreciate
so
it.
much,
Thank you.
honestly. Bear with us 2 seconds
Yeah,
and I'll
no
come and
rush.
see you
I'm
out.
in
And
no
I'll,
rush. I'm
yeah.
here.
So much love
Yeah.
online.
I was going to say, we've probably got,
Lots of emotional comments. It's lovely.
yeah, there you go. So yeah, you've got so much. I mean, let's have a quick look. What have we got? To me, this is why I signed up for this. Yeah, didn't realise how one. Yeah, this is an inspiration. Makes me so glad I'm a CFR. So yeah, thank you, because
I
that's.
don't think you guys know. I mean, on behalf of myself, obviously, I was really fortunate to be in a medical ward. But my dad, when he had his stroke, it was community first responders that got him to a hospital in 10 minutes. He's in a hospital in 10 minutes, and they gave him a shot, and that blocked his. And my dad's totally fine today. But it was because my mom knew, obviously.
What you were,
yep. Like her own community.
Yeah.
She knew what she was doing. She saw the signs, and they were in a hospital in 10 minutes. So it's so quick, I know, but what you guys do is so important, and there's just not enough staff for everybody else. So I just so appreciate. I hope you know that everybody appreciates you guys.
Thank you. I know that'll mean a lot to a lot of people. So it's, we really genuinely appreciate you coming down and speaking to us. Thank you.
I'm here for the coffee.
Yeah, there's no milk, but yeah, no, there's plenty of milk. And biscuits. Did you buy more biscuits? Sorry, guys, online, we've got biscuits and tea and coffee. Honestly, help yourself.
Great, thank you.
2 minutes and we'll come and join you. Thank you, lovely. Thank you. Fab. Slightly emotional, not gonna lie. It kind of makes me, I don't know if you guys, I've met quite a few of you and trained quite a few of you, but I've been a CFR for 8 years, and I know without a shadow of a doubt the jobs that I've been to that have involved patients that have had a stroke, and I've been there and first on the scene. I know how important we are as CFRs, hence why this has kind of been something that I have badgered Vicky to do, and poor Lorna, I've badgered Lorna to do, and I'm just so unbelievably grateful that we've got the audience that we've got to make you guys know how appreciated you genuinely really, really are. So thank you. Right, composure. Last speaker of the evening, by no means least, and thank you for waiting so very patiently, is Naresh. Now, Naresh has come from the Stroke Association, and he's going to talk to us about what they do with the community. So when we have those lovely stroke survivors that are out in the community, how these guys support them. And I think, again, that's really important that we kind of go full cycle, and we've looked at every single aspect. So please welcome Naresh. Thank you very much.
Firstly, I'd just like to reiterate what everyone's really said today, that you guys and girls do a fantastic job. And it's a shame that people like yourselves are never honoured in the King's Honours now or things like that. And it's always usually some obscure footballer who gets to see the Euro OBE, and not people like you. So my hat goes off to all of you, for everything that you do on a daily basis. So my name is Naresh, and I work for the Stroke Association. We're the largest stroke charity in the UK. We're one of the smaller charities. Obviously, we're not nothing like Cancer Research or the British Heart Foundation, but we do have quite a lot of clout when it comes to all things stroke. So really, I've been asked, I know you've been told about ischemic strokes, hemorrhagic strokes, etc. So I'm really just going to give you an overview of what I do and what the Stroke Association do. So our vision really is that for there to be fewer strokes in the UK, and for people affected by stroke to get the help they need to live the best life that they can. And our key message is we're here to support people to rebuild their lives. And how we do this is that we do this through support like I do, and my service is commissioned by the NHS. So it's an NHS service commission. We provide specialist support in various areas. We fund critical research. We campaign for stroke, and we work closely with the NHS to achieve this. And we try and lobby Parliament as and where we can. And we have, our service can't really operate without volunteers, so we have great volunteers. And we fundraise for various causes around stroke. So my service, I'm the stroke coordinator for communication for the Suffolk region. So I cover the whole of Suffolk, except Waveney, because that's with another commission service. And I'm a one-man band, so I cover the whole of Suffolk myself. And I deal with all stroke survivors who are now suffering with communication problems. So that is mainly people who have aphasia. So a day in the life of my job is that we will get a referral from anyone who's 18 or above, and it can be from a professional, it can be from a family member, it can be from a carer. It will come to my services, and as long as their doctor's surgery is with a CCD within Ipswich and Suffolk, then obviously we can work with them, or I can work with them. So my first thing that I will always do with a stroke survivor is I will always try and see them in person if that's what they want. And the first question I always ask them is that, what is it that you want? Your partner is saying, you need this or you need that. But has anybody really asked what you want? What are your goals? What is it that you want to achieve? And some of the times they've said that I'm here because my partner wants you to be here, but I don't really know why you're here and what you can do for me and so forth. So then I kind of give them an overview of what, I can try to do with them. I can't promise them anything because at the end of the day, as the lady before just mentioned, a lot of the hard work comes from them because they're going through this kind of trauma day in, day out. And a lot of my stroke survivors say the very same thing. I hate it when my friends and my family come and see me after they haven't seen me for a couple of months and they say, oh, you're doing all right. You seem good today. But inside, they said they don't really understand what's happening to me on a daily basis. And a lot of them have always said to me that the biggest fear they always have is when they go to sleep. Are they going to get up again in the morning? What's going to happen to them during the night, etc.? So they're really fearful of that, and the anxiety sets in for a lot of people. Depression sets in, and they're struggling every single day. And this is why it's so important for me to understand what they are going through and ask them, what is it that you want? Forget what everybody else wants. What is it that you want? And the vast majority of the time, they'll say, I want to get back to what I was. Now, for some people, like Alex, it may be the case. She can get back her life, etc. But for the vast majority, it doesn't happen that way. They're going to live with some form of disability, or they're going to have some paralysis of some sort. And it's going to be a different way of living. And coming to terms with that must be difficult. I always say to them that, you are my heroes, because at the end of the day, what you're going through, I could never really understand. My mum died from a stroke last year. I looked after her for 5 years, and she had an all-consuming stroke from day one. I never heard her speak again. She was peg-fed. She had atrial fibrillation, hypertrophic cardiomyopathy, you name it. She had it. She developed diabetes. She was paralyzed. She was more like a vegetable. So I understand how hard it can be for family members and what they go through on a daily basis, because I was there. And when she passed away last year, all those emotions came back to me about how I felt really helpless that I couldn't help her. Hence why it's really important that when I do speak to my stroke survivors, what is it that they want? So the service is client led. So in other words, I could be there speaking to them, and then suddenly they turn around and said, look, I don't want to speak to you anymore. Can you leave? That's fine. We'll leave, because it's all about them. It's not about us. We provide a holistic needs assessment. So the needs assessment that we go through is that, firstly, you'll be surprised at how many people have gone to hospital, had their stroke, and for some reason, the stroke hasn't really been explained to them in layman's terms. It's been explained to me in a kind of a medical way, and they don't really understand. So my first question always is, do you actually know what has happened to you? I've had a stroke. Do you know what type of stroke you had? I had a clot. Do you know where it was? Not really. So we look at the medical records, and I say, right, it looks like from here you've had a hemorrhagic stroke. So did you have a bleed on the brain? Oh yeah, I remember that. And then I'll slowly try to explain to them what has happened to them, which they find very comforting, because they actually understand, oh, is that why I keep on getting the headaches? Is that et cetera, et cetera. And then the next question we usually ask, or I ask, is what effect has the stroke had on them now? So what is it that you can't do now that you used to be able to do before? A lot of the time is that, I can't walk unaided, or I get fatigued, because fatigue is a side effect of stroke, or I want the life that I used to have, or I'm getting really angry all of the time. My sleep patterns are all over the place, etc. So we try to explain to them that is a kind of an offshot of your stroke. These things, if I can put it this way, are normal after a stroke, but it's not the same for everybody. So fatigue, you've got to be careful, because we're not there to give advice, we're just there to guide them. So if they are suffering from fatigue and they've got diabetes, it could be the cause of the diabetes that is making them even more tired than they were before. So it's really trying to give them an overview of what is happening to them, why it's happening to them now. Then my next question is usually, I have a checklist, I'm going through that checklist as I speak to you all. How is your current health? How are you feeling today? What has your health improved? Do you think your stroke has improved? Do you think you're improving, or you're not improving? The next question is, do they understand the medication they're on? And usually they'll say, wait a minute, and their partner or whoever will come back with a massive carrier bag full of medication and say, that's the medication I'm on. And we'll try, and then I'll say, do you understand why you're taking that, etc., etc. And if they don't, we'll try and explain as best as we can. But obviously, we'll always come with a caveat. Like, if you don't understand something, or something's not working for you, please go and see your GP. Then I'll always ask them about their mental health. And the vast majority of my clients will be suffering from some form of depression as a result of what has happened to them. And they're finding it very hard, even after some years, to come to terms with what has happened to them. So I'll come on to what we kind of help them with afterwards, in terms of depression and things like that. So that's the next question. Then do they know how to stay well and try to avoid another stroke? So like the professor said previously, follow a healthy diet, try not to smoke, drink too much alcohol, and if they can, exercise as much as they can. So that's the next thing. How are they coping at home? So you'll be surprised, we go into many homes and the home just isn't adapted. It's just not made for them anymore. So have you been speaking to occupational health? So we try and put them in touch with occupational health. Do they get out of the house? And if not, why not? So I don't want to go out. I don't want to see my friends because I feel embarrassed, etc. So that's the next question. Are they having any money issues? Because now they may have been the sole bread provider for the house. And then we'll try and see what benefits they may be able to get in place for them, etc., and put them in touch with the right agencies. What support do they have? So do they need more support? Does your carer need support, etc.? And how is your relationship? This is quite a tough one. How is your relationship changed, or is there any issues within your relationship? So what we're getting to that is that you're a vulnerable person now. Has anything changed that you feel you're not comfortable with in the relationship? So that's the next question. So I then, once we've asked all of these questions, then I come up with a plan with the client as to how we're going to deal with their recovery in terms of their communication needs. So I run communication cafes in Suffolk. I run one in Ipswich. I run one in Bury St Edmunds, one in and recently one we had to close down was in Felixstowe. And that's where I invite, so it's invitation by myself for my clients who I feel would benefit with other stroke survivors being present, and they can communicate. So there'll be varying levels of communication. So any form of communication is good communication. Anything that will get the brain activated, anything that will get their left or right side of the brain engaged is a good thing. So in the groups, it's a safe place, it's a safe environment. No one's going to judge anyone. No one's going to say, why are you talking like that, and etc. I've got a group where someone's had a hemorrhagic stroke and they can't speak. I've got someone who speaks too much. I've got someone who can't speak at all, but can only recognize pictures. So we use communication ramps where we've got various pictures that ascertain, and they said like, I am tired, but a face saying I am tired. And this was used to great effect most recently by our team in the north, in the Wirral. They went into a nursing home where they had quite a few stroke patients with communication issues, and they were struggling to communicate with these individuals. So they went in there, did a bit of work with them. And then there was one lady, an elderly lady there, who was very sad, very down, and they couldn't really find out why, because she couldn't communicate. So they used the communication ramps to ask her, look at the pictures, and she said, I'm really sad. And they said, why are you sad? And then she pointed to friend. So there was one of her really good elderly friends that was in the room next to her. She's not there. So she believes she's died. And that really upset her. And they said, wait. So they took her upstairs and they said, no, there she is. We've moved her to a new room. And they were hugging each other and she was crying her eyes out. So that's one of the excellent ways in which, our communication ramps can help somebody, move forward. And that nursing home has now started to use those strategies with the other patients. Because, just because you're old or, you're in your 90s, etc., doesn't mean you need less support. You need just as much support as the next person. So I offer communication groups in which I design activities myself. So an example would be word pictures. So I designed a picture of an apple and a phone. So if you add the two words together, what do you get? Apple phone. Yeah. And things like that. And they love that kind of stuff, they really engage, etc. I've got my group in Bury. There's an elderly gentleman. He's a bit of a rascal. And I've got another guy who found out that this guy, who was his friend back in the day, was at that group. He's also a stroke survivor. He now travels 2 hours on a bus just to be there so he can have a conversation with his friend. And when they get together, they're like two little schoolboys, always joking and messing around. And I have to sometimes say, look, you need to pack it in now. Yeah, right. But they love it. And it's lovely to see how they kind of engage with each other and they get a lot out of it. Again, those communication groups are guided by them. They're not guided by me. I tell them on any given day. So I may have like 10 in the group and 5 of them say, look, I'm so tired. I've had a rubbish week. I don't want to do anything. I just want to talk to my mate. Go on then, just talk. I can do things with the other people, etc. So any form of communication is good communication. Anything that will activate the brain, because as you will probably all know, in order to connect new neural pathways within the brain, it's about repetition. It's about repeating the same thing so the brain gets the idea that, okay, you want me to do this and not this. We also provide online Zoom sessions. And what that is that any stroke survivor, they don't have to be part of my service. They could be anywhere in the UK. They can log on to our online Zoom sessions, and they have various things that they can listen to. They can take part in. It's around stroke or fun things or activities that they do on a daily basis. So we have online stroke sessions. We have our Stroke Association website, which have a My Stroke guide, which has a wealth of information around stroke, about what everything an individual needs to know about. We refer to other services. So like I refer to the NHS Wellbeing Service for mental health issues. Icanhoe, I don't know if anyone's heard of Icanhoe, which is one of the leading brain rehabilitation charities here in Suffolk. So they do fantastic work with stroke survivors. We also have a service called Here For You. Here For You is a service where we link stroke survivors with other stroke survivors who have the same hobbies and interests. And if they can, they will speak to them over the phone on a weekly basis for a number of weeks, for 40 minutes to an hour. And it's another form of peer support that they get, and they get support, ongoing support. I direct people, and people who know nothing about the NHS non-emergency transport service, which you're probably all aware of, where they can attend NHS appointments and they don't have to pay anything. And they're shocked when I tell them about that, because they've not really been aware of that. We have over 600 local groups within the UK, which are Stroke Association or Stroke Association affiliated. We have carer support groups as well. And I can refer a carer in my region to the Suffolk Family Carers, where they can then refer them on to social services within the council, who can then do a carers assessment. Obviously, we liaise with professionals. I can also do online Zoom sessions with clients who aren't mobile, who can't get to a cafe. We refer to social prescribing teams within the county. They're a really good source. There's an organisation called Drivability, because a lot of my patients want to drive again. So we refer them to Drivability, who can give an assessment on their driving capabilities and whether they would be able to drive and go forward. And then one of the last questions I always ask is how it's to the carer. And I always ask the carers, how are you coping? And 95% of the time, they will be quite surprised that I've asked them that question, because they've said, no one's ever really asked me that question. It's always been about my husband or my wife or my partner, etc. And then, I asked them, how are you coping? And you'll be surprised at the amount of people that are not coping, because they're saying that when my children go home, etc., and the door shuts, it's just me and my partner. And it's difficult because I worry if he or she has another stroke, here we go again, etc. And I worry in the night. I never really get a full night's sleep because I'm always checking, are they okay, etc. They say it's a never-ending story, and I can vouch for that, because, like I said, I did that with my mom, etc. And it was a very, very difficult thing. Is it going to happen now? Is it what's going to happen tomorrow? Or is tomorrow? Is the blood pressure going to go through the roof, or is the diabetes going to go off the chart, etc.? And he was always on edge. And as Alex can probably tell you, her parents were probably the same with her, and so was she probably the same on a daily basis. So it's a kind of a holistic approach to stroke with the stroke survivor at the heart. It's all about them and what they want and what they don't want. So, our service will never be forced on anyone, etc. So like today, I've had a referral from a care home, an elderly lady, and the son has said, I want you to go and see X, Y, and Z. And I said, well, I can't really do that unless your mom tells me, etc. But he says, my mom just cannot speak, etc. And I've said, okay, based on that, I'm happy to go. But if when I get there, there's some eye movement or something, or they're agitated, then I don't really want to proceed. But because it's all based on what your mom wants and not what the family want. So going forward, the Stroke Association are trying everything they can to put stroke on the map, on the medical map. We're still, we're visible as much as we can be. We have people who are stroke survivors who tell their story to the public, etc., and get more support. We come to events such as yours here today to try and advertise our service and, you know, try to get more interest in stroke. One thing about stroke is that it's immediate. The change in your life is immediate. So I always use the analogy, and I don't mean any disrespect when I say this at all, is that, so if someone is diagnosed, if Fred is diagnosed with cancer on Monday at 9 o'clock, on Tuesday, he'll probably still go to Morrison's, but he'll still be coming to terms with his cancer diagnosis. If Fred has a stroke at 9 o'clock, he's not going to Morrison's on Tuesday. He may not be going the next week or the week after. It's so immediate that your life just comes to an end. And I know that with my mom, obviously, and everything changes on that day. You are never going to be the same person again. And a lot of my stroke patients would always ask the same question: when will I get back to normal? And you know, you have to be honest with them, and you say, well, it's going to be a different normal from now on. I'm not saying that you're not going to recover to regain movement, etc., but this is going to be a lifelong process. And unfortunately, the hard work is going to have to come from yourself. I can only do so much to you. And when I obviously tell them, and then they always say, well, everyone says that, what do you know? What do you know about, etc. And then when I tell them that, you know, I've been there with my mom, they kind of relate to that a little bit more, knowing that, okay, fair enough, you've kind of been there, you've kind of done that. And, you know, and they, you know, they respect me for kind of telling my mom's story to them as well. So I'm quite passionate, as you can see, about this field now. And when I started with the Stroke Association, I started last year, actually. I started last year. And it was funny because the Stroke Association, when I had my interviews, etc., they were then umming and ahhing about a start date. And we were saying, well, what about this date? What about this date? And I said, look, just give me a date. So they gave me a date, and that date was my mom's birthday. So maybe it was kind of meant to be. So I'm quite a big follower of philosophy and so forth. So I'd just like to leave you with a quote, which I think is quite relevant to what you do and what everybody else do that cares for people. So this is a quote by William Penn, who's a Quaker back in the day. And he said, I expect to pass through life but once. If therefore there be any kindness I can show, or any good thing that I can do to any fellow being, let me do it now, and not defer or neglect it, as I shall not pass this way again. Thank you very much.
Amazing. Thank you so much. Thank you. Has anybody got any questions, Naresh? Thank you.
We have an Essex equivalent
We did. It was in Colchester, but unfortunately that service has been decommissioned. But that service has now gone to another stroke service. So my colleagues have been paid over to that service. So technically, yes. Yeah. Unfortunately, there's one, like I do the whole of Suffolk, but believe it or not, Addenbrooke is one of the biggest hospitals in this region. There's no service in Cambridgeshire, no stroke association commission service in Cambridgeshire, but they're dotted around all over the UK, and they provide different services, can provide different support, but mine is primarily communication.
Thank you. It's amazing. Yeah. Thank you
Okay.
so much.
Thank
you. That's it, guys. Everybody has spoken. We're good. So thank you for tonight. Has anybody got any questions? Is there anything that you guys want to feed back to us or ask myself, Vicky, Lorna, Alex? Did say that again, sorry? Yeah, Lorna. Yeah, absolutely. I have not forgotten Lorna. Fear not. Lorna would not know. When's the next one? When's the next one?
As soon as we are able.
I'm going to go home first and have a rather long lay down. Genuinely, thank you. It means the absolute world that you guys are here. The feedback that we've had online has been brilliant. You know, it's all to do with giving back to you. You are all volunteers. I am one as well. I know that I'm paid here now, but I have been one for 8 years as well. And that's kind of where this stems from, that I'm so passionate about what you do, what we do. And I think it's so important that you're recognised. So hopefully we'll do another one. We will do another one. I don't think we're going to get away with not doing another one. And you know, there'll be probably many more to come. It just won't be in Harlow. We'll dot ourselves around the counties. So I'm going to hand you over to Lorna, because I know Lorna's probably got a few things that she'd like to say. If there is any questions, obviously, please ask. If not, hand you to Lorna, and then we will close for the evening.
Evening, thank you, and you know, a big thank you obviously goes to Liz and the training team for all that they've done in putting this on, and it is very much around how we, and I think how we've gone that journey through today is you know, actually what do we do with our patients in the community, and then actually how does that onward care go through what Silke was saying about the stroke unit, and from what we've had with Alex and her survivor story, and also about how we then continue that help in the community. And it's also quite nice for us to see our thread throughout that as volunteers. You guys do an amazing job out there, and you are often those first on scenes with our stroke patients, which enables us to actually start that pathway for that patient and make it the best pathway possible. So I just, you know, it's a privilege to be able to be here today and this evening and just say thank you for what you guys have done. Thank you to the training team for what they've done. Thank you to those that have come and shared their experiences and shared their knowledge with us. And from this, I think this is a building block for us as where we start going with more CPD sessions like this, as we say, around the region, you know, and through, you know, it's amazing where we've gone now with technology enabling to have the online capability and have that interaction that we've now got. So I just want to say safe drives home for you all, however far you're coming and going, because we're from different areas out here. And thank you for what you're all doing, and really, really appreciate what you've done. So thank you.
Right, just a couple of things that if we can ask of you before you go home, because it would genuinely be brilliant. On your tables, there is a QR code that's on one of those A4 bits of paper. If you would be so kind, it would be amazing. Take a scan of that QR code. There's a little Microsoft form. If you could fill in that form for me, give us some feedback, tell us what you liked, what you didn't like, we can improve, what you want to see next. There's loads in there. So if you could just fill that out. The guys online, we will get that QR code to you. We will send you the form as well, so you will be able to do the same thing. Again, any feedback is good feedback. Other than that, I think what I can say is thank you ever so much for coming. Like Lorna said, thank you. Have a safe drive home. Any questions, come find us. But if not, thank you for joining us, guys. It's been amazing. Thank you.